NTT 関東病院の落合と申します。非常に資産とお話を聞けて勉強になったんですけれども、ちょっと誤解のないように聞いていただきたいんですけれども、カイザーパーマネンテの成功っていうのは、保険会社原則的にですね、そして営利というか、それを扱うことによってこの利益が得られるという目的があって行われている業態です。日本の医療というのは国民健康保険っていいますか、それで行われていて、原則的にその利益というか、それがこう得られないっていいますかね、決められたお金の中で何かをせないかんという形で運営されている業態なわけです。でそこに新しいその ICT のようなものを導入しようというときに、そのメリットは分かりますけれども、それのベースとなるインセンティブが誰がそれを持つかというと、利用者という場合は医療機関ですけど、医療機関が持つというときには医療機関の持ち出しでそれが導入されていると。この全体をカバーするような形のその ICT を全体に導入しようと、そのためにはそれを維持する人、それからその仕組みを決める人、そういうものが必要なんですけれども、そこの部分というものがこう言われてなくてですね、これを持ち込むということは非常に難しいんじゃないかと。で今回のその被災地の問題が非常に気の毒でありますけれども、これは被災があったから問題ではあるんではなくて、被災のある前からその問題の形のことであって、その中で被災が起きてみると ICT が入っていればもっとより効果的に救済ができたのになというようなことがある、妙にこう喧伝っていうか露見したもんですから、その重要性が言われているけれども、そのことは被災の前からその ICT が入ればできる。だけど誰がどうやって入れるんだって言った時にの問題になっている。そうすると日本の場合にもやはり保険会社が入れるんだ、保険機構が入れるんだとすると、やっぱりそれはその憲法であり国庫であり、それを統括しているやはりその保険、そこがこうトータルにヘルスケアを行う視点から入れなければできないのではないかと思うんですね。そこのところが日本とその何て言うんでしょうか、成功事例のように見えて、これからやらなきゃいけないっていうところのその働きかけがちょっと違うように見えて、増田元知事のお話もそこでちょっと難しいんじゃないかなというようなことを感じたんですけども、それができれば簡単だけども、元からお金とかその人とかそういうこうビジョンが先にあるんじゃないかと思って聞きました。
内田先生、ありがとうございます。
I'm very happy to respond to that. First of all, I'm pleased to say we are nonprofit, so we do not make a profit. Second, I agree with what I believe I understand your point to be. When we got out ahead and invested all of this of our own resources, we made decisions about what we would and would not do in order to put the electronic health record in. The reality is, first of all, the system is only as good as the people who use it. And if the people who use it for profit instead of for improving care and outcomes, it won't yield the results that I was talking about. Second, I would say I do believe there is an important role for government here, and we are experiencing this same phenomenon in the United States, where while we made a very difficult decision to invest ourselves without government resources, now for this country in the U.S. to adopt this, the government is having to step forward and subsidize putting ICT into physician offices and so forth. What I think is more important than that initial investment, however, is how is the ongoing use of ICT paid for? And the decision has been made in our country that we have something that is called meaningful use, which essentially means that if you have ICT in place, electronic health record, and you use it to improve care in a series of ways that are specialized, you can get a bonus payment, in effect, a quality reward to help offset that. So that is an attempt. It may be somewhat imperfect as it's designed now to say that over time providers who use ICT and improve the quality of care and the outcomes with it will get ongoing support for that. But those who install it and don't get those results will not get the same advantage. We'll see whether that works. But I think that to your point that this is something that is beyond the individual provider decision in terms of both the initial investment and the ongoing cost, that's a very important point, and I would agree with you.
内田先生ありがとうございます。まさに震災前からも問題があって、そこを解決するためにいろいろとプラットフォームを作っていく必要性があるということです。ちょっと時間がもう数分になってしまいましたのでまとめたいと思うんですけれども、実はその医療 IT に関しては昨年のサミットでも議論をいたしました。地震の前から医療先機構としても CSIS と政策提言を一つ作りまして、今日はCSIS の副所長のスティーブン・モリソンさんいらっしゃってますけれども、彼のイニシアティブのもと医療 IT のスキームといいますか政策提言も作らさせていただきました。その時にずっと日米医療政策のプロジェクトとして、地震の前からコミットしてくださってたのが、バイアン・バイルズさんでいらっしゃいますけれども、バイアンさんも 3日にかけて3件回られて、そのコメントと、今後の展望というところを少し最後にまとめとしてお言葉頂戴できますでしょうか。
Thank you very much. My comments will really reflect our discussions in Tohoku, and I'd like to echo Dr. Baxter's comments. I think we found great respect for those working, very dedicated people working very hard to solve the problems before them. But I think we also saw that there was a broad opportunity to rebuild but also redesign at the same time, or rebuild better, and redesign the healthcare system for higher quality and lower costs, a model system for not only Tohoku but also for all of Japan that would be more effective, higher quality, and more efficient. And of course the three areas are hospitals, which is most related to rebuilding, but rebuild a tiered system with lots of primary care locally, and then regional hospitals for less frequent but nevertheless common instances where people need to be hospitalized, and of course then central medical centers, teaching hospitals with the very best, the various high technology services. But again, to get care where it's both the most effective, the highest quality, but also most efficient, not only the provision of the individual care, but not providing excess capacity that moves people into the hospital who don't really need to be there. The second area, of course, is physician care, and again the focus is much more, we heard, on training and supporting, once they're trained, primary care physicians. And I think that's an issue, of course, for Tohoku, but also for the nation as a whole, defining physician specialties and particularly training people who will take pride in being primary care physicians and focus on prevention. And then I think there's been a lot of discussion of ICT, healthcare information technology. And I think the point there is this is a sort of a once, probably in more than a lifetime opportunity to get it right. And that, I think, has to be done, and our lesson from the United States is nationally, that to have one system in Fukushima, another in Miyagi, and another in Iwate does not make sense, let alone all the other prefectures to get systems. But once they get built the first time, to then change those systems and to try to coordinate later will be even more difficult. And I know national standards are always very difficult to agree on. Ray has lots of experience and comments or advice in that area. Again, I conclude the officials and the providers working in Tohoku were working very hard to accomplish the important, difficult recovery task. But I think we saw a need perhaps for a really broader perspective, a broader discussion, that obviously there were three prefectures, there were three stakeholders, the prefecture itself, of course, and the hospitals, the medical center, the medical school, and then the local providers, hospitals and doctors. So three prefectures, three stakeholders, and then three issues. hospital rebuilding, maybe redesign, primary care training of physicians, and then ICT. And that among the 3 prefectures, the 3 stakeholders and 3 issues, each individual was working in his or her own specific area, but there wasn't broad discussion, broad perspective, I think, along some of the points that Dr. Baxter made. So I would think this may be something that HGPI, perhaps together with CSIS, perhaps Kaiser Permanente and others, could provide some support or some continued discussion. And I think, again, there may be a possibility to facilitate this discussion with vision, again, not only in specific individuals working on specific problems, but more broadly, not only in Tehuco, but perhaps even at the national level. So again, I think I join Dr. Baxter in thanking HGPI and all, again, the hardworking people we saw in Tehuco for their time. And it was very impressive, but it certainly also leads to observations that something probably broader will need for this to be the most effective in Tehuco, and then nationally.
ありがとうございます。バクサーさんのディスカッションの中でも、先ほど増田さんからも各都道府県の人たち本当に頑張っているとおっしゃってました。そして同時にコーディネーションが必要だということで、若手の各都道府県庁の若手の医療政策の担当者をバクスターさんのモデルを見せるために、カリフォルニアに連れて行くための予備を出そうじゃないかということもおっしゃってくださっていますので、そういったところでもCSIS、HGPI のですね、今後のプロジェクトにもつなげていただければなというふうに思っております。これにて本セッション終了したいと思います。次のセッション12時30分からですね、時間通り進めたいと思います。本当にご多忙のところ、武藤先生、正先生にはお越しくださいましたことを改めて感謝申し上げます。そして、遠くから太平洋を越えて渡ってきてくださいました、2人の有識者にも大変感謝を申し上げたいと思います。皆様本当にありがとうございました。
ありがとうございました。それでは次のランチセッションは12時半から予定通り行いたいと思いますので、ご協力お願いいたします。